All for listening in today. I'm excited to share with you. This is actually my second time doing this class. I recorded it yesterday morning. It was Thanksgiving morning, put all the details together and uploaded the video to YouTube and realized that the volume, for some reason, my voice was not working. So if you listen to that first lecture without sound, I apologize for that. This one, I hope, is going to be better than the one that was yesterday. But I had given the talk yesterday morning. It was Thanksgiving, to say thank you to all of my colleagues, all the professionals that I have learned from, the medical doctors, the physical therapists, the psychologists. Listened to a lot of pastors over the years, different things in podcast, YouTube format. I thought, you know what, I'm gonna upload some things that I've learned over the years treating patients who are dizzy. When it comes to taking a good history, I've learned that there is an art to it, and it's been a really amazing journey for me. So I thought, I'm going to share this. This is also part of a course that I'm giving in February to a great group of therapists, and so it's a chance for me to practice that too. But so hang in there with me. I'm going to teach the first maybe 10 to 15 minutes as though I'm speaking to patients and to healthcare providers. And then after I'm done with that first section, then I'm going to just talk as if I'm speaking with therapists. But whether you're a therapist or not, you're welcome to join in and listen the whole time. I'd love to have you participate. So, learning the dizzy language. I have learned that we all speak our own dizzy language. The word dizzy means whatever someone wants it to mean, and very few people know what the true definition of dizzy is. And for instance, I'll have patients say that they're lightheaded, and I'll assume that they mean a feeling like they could pass out. But most of my patients, when they say lightheaded, mean that they feel off balance. So what dizzy means to medical providers and what dizzy means to the general population are two different things. Even spinning can mean different things to different people. So I've learned that there is a dizzy language that we all speak. We all speak our own dizzy language. And so what I want to do is try to get us all on the same page and help you learn how to speak that dizzy language, whether you're a patient or you're a healthcare provider trying to help your patients who are dizzy. So here's what I really want you to know. The most important thing when it comes to treating patients who are dizzy, in my opinion, is knowing the big three. The big three is key. The big three are triggers, timing, and nystagmus. Again, the big three are triggers, timing, and nystagmus. Now, the first two of those, triggers and timing, have to do with the history, how you describe dizziness, how our patients describe their dizziness, or the questions we ask in figuring out what the patient is feeling. The third element is nystagmus, and it kind of fits in with the history, and I'll explain how in a moment. But our big goal is, I love Dr. Newman-Toker and Edlow. They created 4 syndromes that they use in the emergency department setting to try to figure out why their patients are dizzy in that setting. And this was also published in the Clinical Practice Guideline of BPPV in 2017. I have found this tool, the 4 diagnostic categories, to be very true, very effective for the patients that I see who are dizzy. Now, to give you a little background on me, I have treated dizziness since the year 2000. So I've treated probably over 14,000 people with dizziness. And I'm going to share why that matters in a moment. But I have found this approach that I'm about to share with you to be the most valuable. My goal when a patient comes to see me is to figure out if they have acute vestibular syndrome or were in acute vestibular syndrome, triggered episodic vestibular syndrome, spontaneous episodic vestibular syndrome, or chronic vestibular syndrome. Now, I just want to highlight a few of the most common problems in each of those 4 syndromes, and then I'm going to tell you why they're important and why they're so helpful. AVS, the most common problems I see from that are vestibular neuritis or labyrinthitis, and sometimes brainstem or cerebellar strokes. TEVS, I see most of the time as BPPV and sometimes orthostatic hypotension, or more likely orthostatic intolerance. SEVS, I tend to see people with migraine and less common Meniere's disease, sometimes TIAs. And then chronic vestibular syndrome, I tend to see people who I say are in the vicious cycle of dizziness, or you may have heard 3PD. Okay, so that gives you a little bit of background on the 4 major syndromes. Let me break those down a little more when it comes to history. The first thing I do, okay, when a patient comes to see me who's dizzy, or when I'm have friends call me, or I'll have people text me and say, hey, I'm dizzy, what should I do? My goal at first is to figure out if there's a trigger or if their dizziness is simply exacerbated. Let me explain the difference. Triggered dizziness is when there's no dizziness at all, and the person does something, they move, or they eat something, or they're in an environment that triggers their spell. Exacerbated dizziness is when there's always a baseline dizzy feeling that is then made worse when they do things. Exacerbated dizziness is not triggered dizziness. So when I take my history, okay, I'm going to break this down much better after I get through this just general overview. When I take my history, the first thing I want to do is find out, do any sensations get worse when the person, or any sensations provoked by laying down, rolling over, bending over? Those are the biggies, okay? Why do I care? Because some of the most common problems are triggered. Look here, TEVS, okay? TEVS is a triggered episodic vestibular syndrome. Usually it's BPPV. BPPV is the most common reason people are dizzy. So I will start with that. Do they, or have they, are they, or were they ever experienced BPPV? Because often BPPV is the trigger that also sets off what I call the vicious cycle of dizziness. So I want to know, do any sensations get worse when they lay down, roll over, bend over? Because if so, I'm thinking they're probably either in or have been, are they, were they, in TEVS, okay? Now, you'll see up here on the top of your screen, are they, were they, and or. Are they, were they means, are they currently having the problem, or were they having the problem? Patients will come to me as though they're having the problem in the moment, when really the problem was present days, weeks, or even months ago, but they still perceive the problem to be present. So when I'm asking my questions, I'm thinking, is this something that they're having right now in the moment, the last few days, few weeks, or is this something that they've had weeks, months ago? Okay. The other thing I do is over here, I don't just think about them having one problem. I think of them having several problems. So I think and or. That's what that sign is and or. So don't think, is it AVS or TEVS or SEVS? Think, is it TEVS and CVS? Something like that, okay? So I start with my triggers, then I go to my timing. Timing is very helpful. If they have any spells that are made worse with moving, I'll say, if you hold still and don't move, how long will that intense sensation last? If they tell me seconds, I'm thinking TEVS. Days to weeks, I'm thinking AVS. Minutes to hours, I'm thinking SEVS. And weeks to months, I'm thinking chronic vestibular syndrome. Now, I am a physical therapist, so I see patients who come and see me off the streets. I'm not an emergency department. So I want to be clear that if you have a patient, or if you are struggling with dizziness, if you wonder if you have acute vestibular syndrome, it's not something you have to wonder about. It is so intense that you will be feeling a crazy, intense spinning sensation. You will be likely getting very nauseated, very sick, probably won't be able to walk. Most likely you're either going to be taken to the emergency department or you are going to be confined to your room because you cannot move. But every now and then I have these types of cases come through. But you could imagine if you were feeling AVS, any movement you do is going to exacerbate that baseline dizziness, but it's movement's not going to trigger it. So coming back to triggers and helping you understand the difference between triggers and exacerbated, that is how you would know if a symptom is being made worse or if it's simply being triggered. And to be clear, spontaneous episodic vestibular syndrome, if you're in the midst of a migraine, if you're in the midst of Meniere's, if you're having a TIA and you move, your dizziness will get worse. It'll be exacerbated, but movements will not trigger that type of dizziness. Okay. Chronic vestibular syndrome, that could be like, maybe you have anxiety related spells, or you've become visually dependent, or your neck is extra tense, or you're in avoidance, you don't want to move. So when you do move, you feel worse. You'll have a mixture of triggered and exacerbated forms of dizziness with chronic vestibular syndrome. So the big take-home lesson here is that if a patient has dizziness, if you are a patient and you're battling dizziness, you will get more help if you can figure out what your triggers are, what the timing to the triggers is. And the last thing is that I want to talk about, and we'll get into more detail here in a moment, is nystagmus. Okay. So when we come back up here, if you're battling dizziness and every time you go to the doctor, they can never find a problem, what you do is you have your patients, or if you're a patient, you take out your phone during an attack and you video your eyes. Okay. Video your eyes, come up kind of close, make it so that your eyes are the only thing on your screen. Have somebody do it for you. If you're in a crazy spinning attack, you're not going to be able to have the clarity to record. But most of the time I have patients who have loved ones do this, or the patient will actually do it themselves. Hold the video camera up, look straight ahead for about 15 seconds, look to the right for about 15 seconds, look to the left for about 15 seconds. And whether or not nystagmus is present and the direction that the nystagmus is occurring will provide amazing information to your healthcare provider if you can get that recorded in the moment. So if you can gather the most important, the big three pieces of information, if you're battling dizziness or if your patient is battling dizziness, that will set you off for the greatest amount of success to get help. And if what I'm saying, if you're a patient and you're battling dizziness and you figure out what your triggers are and your timing, and you record your nystagmus and you take that information to your healthcare provider, and if they're not able to use it, find someone who is, because that information has guided me greatly in helping patients get help. Either it helps me help them, or it helps me refer them to someone who can help. All right. So that's just a general overview, kind of the big picture of where we are going to head now for probably about the next 45 minutes. What I would like to do now is take a moment to share with you the journey that I have been on over the years. Okay. Taking a dizzy history, I have learned there is not a one size fits all approach, but I have learned that there are a few approaches that work for most people. And so I'm going to share with you all what that is. First, I'd like to share with you what I learned back at Emory University with Dr. Herdman in the year 2001. I'll never forget sitting in her auditorium there when they shared a quote from Dr. Joel Goebel that said 75% of patients can be diagnosed by history alone. Now, I had heard that from Dr. Goebel before. He's a great ear, nose, and throat doctor, one of the pioneers of dizzy therapy and dizziness. But he said 75% of patients could be diagnosed by history alone. And in that moment in time, I remember them saying one of the most important questions was, what do you mean by dizzy? And so I got real excited and real passionate about that question. And I'm going to share with you what happened as a result of that. But before I do, let me give you the general overview of how I take a history. And I want to say that I think that there's nothing more important in the patient exam than the history. And if it's done properly, it will guide you to great success with pretty much all of your patients. So step one is this dizziness intake form. Now, this form was created by several of my colleagues and myself when we were completing our DPT. And this form has about every question you could imagine of anything that could potentially cause dizziness. And so it is extremely valuable. This is 4 pages long. And I highly recommend getting to these questions in one way or another if you are not sure why your patient is dizzy. Ideally, having them fill this out in the waiting room would be best. Don't forget the dizziness handicap inventory. Okay, so this is step one. This is patient walking into the exam, into the clinic. How do you start? Or you have them fill this out online at home and they bring it in. If possible, having an opportunity to look at it ahead of time is even better. So you start with that. Be sure to complete the dizziness handicap inventory. And then step 2 is I have a template that I have my patients that I complete, and then I've had my students who hang out with me. They complete this template. Okay, and I'm going to show you what all this is in a second, but I want to take you through a stepwise big picture. So there's a template, the way to ask questions. Step 3 is I have a common problem screen. So that's what I'm going to show you right now. Okay, step 1. And before I do, I want to kind of give you a history of where this began. So I used to begin with the description of what do you mean by dizzy? Okay, so I would have my patients tell me what they meant when they said they were dizzy. And it became like an interrogation. And I remember when I would do it this way. First thing, I'd have patient walk back, they'd sit down in the exam room and I'd say, okay, what do you mean by dizzy? What do you feel? And they'd kind of get intense on the edge of their street and say, well, on the end of their seat and say, I don't know what I feel when I'm dizzy. And I'd say, well, what does the sensation feel like? Say, well, I don't know, just dizzy. Well, what does dizzy feel like? Use a word to describe dizzy other than the word dizzy. So it became intense. It became like an interrogation, like I was an FBI agent sitting over someone who had committed a crime. And this intense back and forth started to occur. And I mean, I would feel exhausted after taking patient histories, and I would see, 9, 10 dizzy patients a day and feel wiped out by the end of the day. And my turning point was when I decided to alphabetize all of the different dizzy sensations that people gave me when they'd say they were dizzy. So I alphabetized what they said. And look, guys, look at this list. I remember when I made the list, I thought, oh, I won't come up with more than 70 descriptions, but I kept going. And then I remember when it got to 150 and I thought, well, I'm not going to stop now. So I kept keeping track and I kept alphabetizing all the different descriptions of what the word dizzy meant. Head is in a dryer, head is in a fishbowl, head is plugged up, head is swelled. Everything is leaving your head. Everything isn't clicking. Everything shifted. Everything turned upside down. Everything went to the top. All the different lightheaded sensations, like you could pass out, like it's in the back of your head, like there's an off balance feeling, or like you're a beach ball or a volleyball, or like a bobblehead, like I was being bounced on a trampoline next to a porcupine. I mean, these were the descriptions that I do get, and that I get, like a like a yo-yo, like a zing, like a woo in my head. But look, I'm up to over on this list, there are over 415 descriptions. I'm actually up to 435, and I stopped keeping track because I think we all got the idea that dizzy can mean anything at all that a person wants it to mean. And so that's how I would start. And I would start with, tell me what you mean when you get dizzy. And then I did the right thing. I took their dizzy description and I would type in, okay, dizzy means lightheaded. And does the lightheaded sensation get worse when they roll in bed? So I'd go from the description to the trigger, and then I'd go from the trigger to timing. And that was very helpful. And then I would go after that and I'd say, okay, other than lightheaded, do you have any other dizzy feelings? Well, yeah, I feel off balance. And then I'd go through all those same questions on the off balance sensation. And I'd realize, people had 5 or 6 different dizzy sensations. And that was all fine, and it was appropriate, and it worked, and it will still work today, but it didn't get me the quickest, most efficient, most clear results. So that's what I want to say is, first off, I'm going to share with you what the better approach is. And I want to say, beware of the trap of it. The trap of it is when you say, what makes it worse? How long does it last? It could mean anything you want it to mean. So you've got to use the specific sensation that the person is that they experience. And I'm going to show you how to do that. So let me show you the algorithm that I use when a patient is dizzy. The second the person walks into the clinic, they complete that dizziness history intake, and I make sure they do the dizziness handicap inventory. Now, after I finish with one patient and I have the chance, I walk up, I'm looking for my patient in the waiting room. If they're in the waiting room, I'm trying to decide, are they in acute distress? Now, what I mean by that is, are they sitting there with a trash can, with their head in their hands? Do they have sunglasses on? Is someone else filling out their history intake? If they appear to be in acute distress, then the very first thing I'm going to do is I'm going to walk up to them. I'm going to look in their face. If they have glasses on, I'm going to ask them to remove their glasses. And if they're in acute distress, I need to decide if there's a life-threatening situation going on. Are they in acute vestibular syndrome? I have had patients come and see me who are in acute vestibular syndrome or are in spontaneous episodic vestibular syndrome. And so what I do in this case is they've completed their history if able. If they're not able, it's because they're too sick or somebody else is doing it for them. I walk up, I do the HINTS plus test battery in a neuro screen. HINTS plus test battery, head impulse, nystagmus, skew eye deviation, do they have hearing loss? And I'll do a neuro screen, okay? Now, it's not in the scope of this presentation to go over what all of that means, but I have had patients who I send immediately to the emergency department who have gone on to have strokes. I have also had patients who they pass that screen, we talk in detail, and it turns out they have vestibular neuritis or labyrinthitis, okay? So I look face to face, are they in acute distress? If yes, do the HINTS plus test battery, do a neuro screen. If it's positive, you send them to the emergency department immediately. If it's not positive, you could consider neuritis or labyrinthitis or something else, but they could also still be having a stroke. So you need to know that you know what is wrong with your person if they are in acute distress when they come to see you, okay? If they are not in acute distress, which is the way most of my patients come to see me, they're usually not in terrible, miserable, oh my gosh, I can't walk, coming in a wheelchair distress, okay? People are miserable, but they can usually walk, or they walk holding on to someone. There's a difference. So if it's face-to-face, I'm seeing them, they're not in acute distress, then right here, I explore my triggers. Now, what does that mean? Okay. Take the dizziness handicap inventory. I'm looking at it. I'm walking back with them. I flip to the questions on the DHI that ask, do any sensations get worse when they lie down, roll over, bend? Well, that's not on there. Rolling over or bending over or tilting their head back is on the DHI. If they've marked yes, okay, or even if they did not mark yes. If they marked yes, I get excited because I think, okay, I know what this is, most likely. If they didn't mark yes, then I'm thinking I know what it isn't, but I'm still going to explore it, okay? So I'll start with my triggers. As soon as they sit down, instead of going to what do you mean by dizzy, okay, I say, if you hold perfectly, if they sit down, I say, do any sensations get worse when you roll over in bed? Or if they've filled out the DHI and they've marked yes, that they have a sensation that happens when they roll over in bed, I'll say, I noticed you marked that something happens when you turn over in bed. Do any sensations get worse when you roll in bed? So I just repeat the same question that they've already answered. And they will often say yes, okay? If they say yes, I will say, does that same sensation get worse when you first lie down or when you bend over? So I'm exploring the triggers. If they say yes, okay, then I'll say, how would you describe that sensation? Okay, I'll either say that, this is where it kind of branches into how I feel, if how clear this person is going to be, or I'll say, if you hold perfectly still, I'll go right to timing. If you hold perfectly still and don't move, how long will that sensation last? Okay, so I'm exploring these key triggers. If they say that they do not get dizzy when they lie down, roll over, or bend over, then I say, do you lay down, roll over, or bend over? If they say, well, no, I can't lay flat because I have GERD, or I can't lay flat because I have back pain, or, I can't roll over because I've had a hip replacement, or I don't sleep on my side because I have a BiPAP, a CPAP machine that I sleep with, then I know that the trigger questions aren't really that valuable because they're not doing those things. However, patients will often say that they don't get dizzy when they lie down, or they don't get dizzy when they roll over, but they're not lying down or rolling over. So it's not an accurate answer. Okay. If they say that lying down, rolling over, bending over does make them dizzy, then I'll say, will it also happen when you sit up or stand up? Now, why would I exclude sitting up or standing up in those trigger-based questions? Because sitting up or standing up can also be caused by orthostatic hypotension. So if they say, yes, it happens when they sit up or stand up, then I think, okay, if it didn't happen when they lay down, roll over, bend over, but it does happen when they sit up or stand up, then I'm thinking maybe orthostatic hypotension. If it only happens when they lay down, roll over, and bend over, then I'm thinking BPPV. But if it happens when they lay down, roll over, bend over, and come up from lying down, and sitting up from standing, and coming up from being bent over, I think, well, it's probably still just BPPV, but maybe there's an orthostatic hypotension or intolerance component. Okay. Once I've explored my triggers, then I go to timing. And I have this all written out, and I'm going to explain how this actually looks. I'll go through a real patient case with you in a moment. But then I go to my timing questions. And my timing questions, usually the way that works is if they've marked something in the DHI, okay, happens when they roll over, happens when they bend over, I'll go to that triggered question and say, when you get dizzy rolling, if you hold perfectly still, so I go to duration. If you hold perfectly still and don't move, how long will it last? So during the moment of the attack, how long will it last? If they say, oh, usually they'll say 2 or 3 minutes. Then I'm thinking likely BPPV, okay, or orthostatic stuff. If they say longer than 5 minutes, it's less likely BPPV. Then I'm wondering if something's being exacerbated or if they're in a chronic vestibular syndrome or something like that. So if I've started with triggers, then I go to timing. That's how that works. Okay. Now, let's say I start with just timing. let's say the patient seems too confused and they just won't answer my questions, and I try to ask and they keep going off into stories and things, and it's like I'm not getting anywhere. Then I will start with the question of, are you dizzy right now as we speak? Okay, so it's kind of a, is your dizziness continuous, or does it kind of come and go? How long does it last? But are you dizzy right now as we speak gives me a starting point with them. So if it's continuous, then I know, okay, this is a certain type of sensation and I can start to explore more. If it's not, how long will the intense feeling last? So I go to the duration there. And another duration-based question is how long will the entire spell last? It kind of in its active state. In other words, if the patient's had this before, maybe they had it a few months ago, a few years ago, how long do these attacks or these spells of vertigo tend to last? Meaning, well, they usually last a few days and then they go away, or they usually last weeks or months or years, okay? Then I'll say, do you get this sensation every day? So I go to frequency. Do you get it every day? Do you get it several times a day? How many times a day do you get it? Do you get it a few times a week? You know, how many times a week? Why does all this matter? Because all these triggers and timing-based responses can be plugged into our algorithms that help us know why people are dizzy. Okay, it helps us figure out their diagnosis, because each problem that we went over in our pathophysiology section has specific responses that make it unique, make their problem unique, and help us figure out why they're dizzy. Finally, with my timing-based questions, I like to know when they last felt the sensation and how the sensation has evolved over time, okay? How many spells have they had, say, in the last 10 years? How many spells have they had in the last 5 years, in the last several months? How is this occurring? Is it getting better? If zero's no better and 100% is back to normal, how much better would you say it is now? So I like to go through those timing-based questions. And then I take the responses to their trigger-based response, their trigger-based responses, their timing-based responses, and I plug their responses into our vestibular categories sheet that I went over before, okay? And then that helps me figure out, oh, this person probably has Meniere's disease. They also have BPPV on top of that, and they're in the vicious cycle of dizziness. So that's kind of where this leads me. Now, let's go through a few case examples, and I'm going to show you the tool that I use to help with this. So now I start with triggers and timing, like I mentioned before. And I'm going to say, let's pretend we have a patient. And the way I do this is I'll start, and you can see where I've kind of filled this out. Do any sensations I'm walking back with them, and I've looked in their DHI and they see that something happens when they roll in bed. And so I'll say, do any sensations happen when you roll over? They'll say yes. Okay. Which side rolling? Well, let's say to the left, rolling to the left. Will it also happen when you bend over? Yes. How about lying down? Yes. Okay. What about head back? Yep. Okay. So I know we got our triggers. So then I'll say, if you, how would you describe that sensation you get when you roll to the left, when you bend over, when you tilt your head back? And they'll say spinning. Okay. Now at this point, it's important. This is where the trap of it comes in. You don't say how long does it last when you roll over, because they might think you're asking about the nausea, the motion sickness, the foggy feeling they get in their head. You want to ask them, how long will the spinning sensation last? So this is the beware of the trap of it. Don't say it. Don't ever say it. Give the specific word that they're using. So if you hold perfectly still and don't move, how long does the spinning last? Oh, it lasts less than a minute. Okay, good. When did you last feel the spinning sensation? Well, felt it this morning getting out of bed. Okay, this morning. Okay, do you feel it every time you're in bed? Yeah, pretty much over the last few weeks. And have you ever had it before? Well, yeah, I had it about 5 years ago. Ooh, interesting. How long did it last then? I'm adding in this one. Oh, it went away in a few days, but now this is lasting. When did it start? Well, this is lasting 6 weeks. Okay. All right. And do you feel that spinning sensation right now as we speak? So this is just kind of a trick question. I'm making sure that they are describing their sensation accurately and that I understand what they're feeling. Well, no, I don't feel spinning unless I lay down or roll over, bend over. Okay. Are there days since you've had this where you don't feel it at all? Well, only if I move carefully. Okay. And that's because I'm trying to test and see if this is coming and going on its own. And well, okay, other than that spinning sensation, when you lay down, roll over, bend over, are there any other dizzy sensations you get? Well, yeah, I feel kind of lightheaded. Okay, so let's explore that lightheaded feeling. Will the lightheaded sensation get worse when you lie down, roll over, bend over? No, that's different. The lightheaded feeling doesn't happen then. That's more the spinning. Okay. Well, let's talk more about that lightheaded sensation. How long does that last? Well, I kind of feel lightheaded constantly. It's always there. Okay, so you're saying last maybe hours? Well, yeah, I'd say hours. When did you last feel it? I feel it right now as we speak. Well, have you ever had that before? Well, no. Okay. When did that start? Around the same time as the spinning started. Okay. Do you feel that sensation sitting here? Well, they've already told me they did. So some of these questions you can kind of jump over if they don't make sense. Yes. Are there days since onset where you don't feel the lightheaded sensation at all? Well, yeah, I have some days that are better than others, but it always seems to be there. Okay. Other than the spinning and the lightheaded sensation, are there any other dizzy sensations you get? Well, yeah, sometimes my head feels heavy. Okay, well, let's go through those questions again. So I'll do the same thing. So now I know I have a patient with triggered spinning with constant lightheaded and constant heavy sensations. Now in our pathophysiology, we discuss what all these different sensations mean, but I know I've probably got a patient with BPPV, and then they probably are getting the lightheaded feeling and foggy, heavy head sensations probably coming from their neck. But that's how valuable this tool is. Okay. That's how I keep things organized, and it ends up working out great. Now, let's go through a case where triggers, for some reason, you start with triggers and it just isn't working. It seems like the patient is not answering your questions. It seems like you're confused. For some reason, there's just not a mesh that helps you know where to go. So what I'll do then is I'll start with my timing-based questions. And I'll just say, right now as we speak, patient walks back. We've been talking. I feel like I'm confused. Okay, right now as we speak, do you feel the sensation that you're here for? Well, no. Okay. When you get the dizzy sensation you have that you're here for, how long does it last if you don't move? Well, it lasts seconds. Okay. Do you feel it every day? Yes. When did the problem begin? Well, it started about 6 weeks ago. And how long has that entire spell lasted? How long how long has that been going on? Well, obviously it's been going on for days. Okay. All right. Okay. So that sensation that we're talking about right now that you're saying lasts seconds, how would you describe that feeling? Well, it's a spinning sensation. Okay. Will that spinning sensation get worse when you lay down, when you roll over, when you bend over, or when you tilt your head back? Well, yes, it does. Okay. So then I go through my trigger questions. And then from here, I say, okay, are there any other sensations other than spinning that you experience? Well, yeah, I feel lightheaded. Okay. So type that down. And in my history, the way this looks is I usually have dizzy 1 equals spinning, increases, lying down, rolling over, bending over, duration, seconds, onset, 6 weeks ago. Dizzy number 2, lightheaded, duration, hours. So I go to triggers, timing, description. I'm constantly going back and forth with all those. Okay. So I'll go through that same approach, just like we just described, with my timing based questions. All right. So this is very, very helpful. This is a very helpful approach to helping your patients who are dizzy. And if you say, well, how do you know this works for you? But it doesn't, would it work for other people? And I'll tell you, I've had 24 students with me over the years, and my students who embrace this approach, they learn quicker how to do vestibular rehabilitation, and they get more results faster with their patients by following this approach. So that is how you start out. You start out with your dizzy intake. You start with your dizziness handicap inventory. Then you go to your triggers. Then you go to your timing. Now, once you've done that, there are some overarching questions that I ask all of my patients. All right. And this is a tool that I've put together for you if you are still kind of just first starting getting into treating patients who are dizzy and you're trying to figure out your groove. This tool is very helpful in figuring out the most common problems that I, as a physical therapist, tend to see. So this isn't necessarily appropriate for a neurologist or an ear, nose, and throat doctor or an emergency department physician, but it is very helpful in the therapy world. And so let me go through it. So you've asked your triggers and timing questions, and let's say you're confused and you're still not sure, okay? Well, do these quick screens with these major problems. BPPV screen. Any sensations worse when you lie down, roll over, bend over? Do you avoid moving? If you hold perfectly still and don't move, how long will it last? I know I'm repeating myself. Do you feel a spinning sensation or like you could spin? If a patient says it's more like they could spin, it could be that their BPPV is healing, but they are still perceiving the pre-spin as a spin. And so that just helps you understand why your exam would be normal, even though the patient is speaking as though it's present. And so I help the patient understand that a feeling that it could happen is not the same as the feeling that it actually is happening. And I also ask, do you have any hearing loss? So hearing loss should not be present with BPPV. If it is, then I'm concerned that there's a vascular problem causing BPPV that could be a sign of something more serious to come, and that would be a case where benign paroxysmal positional vertigo is not so benign after all. So hearing loss is a question I ask all of my patients, and I'll kind of go through those screening questions here in a second. Neuropathy is huge in my world. Many of my patients have neuropathy, even the ones who are there to see me for BPPV or just vestibular neuritis or labyrinthitis. Many of my patients also have neuropathy. And so I'll say, while they're with me, is the problem of dizziness that you're here for, is it only present when you're on your feet? And if they say yes, so I'll say, you mean it doesn't happen when you're sitting? Well, no, I don't feel it when I'm sitting. Or it doesn't happen when you're lying down? Nope, I don't feel it when I'm lying down. I only feel it when I'm on my feet. Then I think, okay, they either have neuropathy or they have maybe a bilateral vestibular loss or something in close to that nature. So I'll go through then, are your feet numb, tingly, or do your legs feel weak? And if they say yes, then I'll think, okay, I bet we're dealing with a little bit of a neuropathy component in there too. And I'll maybe listen for loud walking to hear if their feet are slapping on the floor or if they feel like their feet kind of smack down in a loud fashion. So that's my neuropathy screen. See that a lot. If you're a dizzy patient working with patients who are dizzy and off balance, if you're a dizzy therapist, make sure you're screening for neuropathy. My central screen is something I do for everyone. Every single one of my patients, I ask any history of head or neck injuries. I want to make sure there's no dissecting arteries going on. I want to make sure the ligaments in the neck are stable before I start doing any type of neck testing. Has there been a recent virus or birth control or a history of migraines with or without aura? If it's a migraine with aura and they're on birth control and they've had a recent virus, there's a higher risk of stroke, vertebral artery dissection in these individuals. Has there been any hearing loss or hearing changes? Hearing problems, sudden hearing loss, hearing changes can come from central issues, vascular problems, and I want to be aware of that. How's blood pressure? How's pulse? Is the blood pressure high? Is there a history of atrial fib? Are there other arrhythmias going on? Any family history of early heart disease or neurologic issues? Any new numbness, tingling, weakness, slurred speech, trouble swallowing, trouble speaking, any changes in taste, smell, all of those things I ask every single patient, and I write down yes or no responses based on how they say that, because serious problems can be lurking behind peripheral problems. So I'm always extra careful. And the truth is most of our patients are worried that there's something serious going on. So I need to be hyper vigilant, and I am, about whether there could be something serious going on in addition to something that seems not so serious. Cervical screen, does your head feel foggy, fuzzy, or full? Do you have any history of head or neck pain, headaches, neck pain, stiffness? Does your dizziness feel better when you lay down? If it gets better when they lay down, it could be that their neck is resting, their muscles are turned off, their joints aren't having to be activated, their nerves are resting. And if it feels better when they lay down, then I think, well, maybe it could be coming, some of this could be coming from their neck. Do they have, again, same question, history of head or neck injuries? And if I do neck therapy, or if they've seen a chiropractor, or they've been to other therapists and they treat their neck, do their sensations get better? So that's for the cervical screen. And many of my patients, many of my patients with dizziness have neck issues. And when I treat their neck, their dizziness gets better. Visual dependence. Visual dependence is when you rely too much on your eyes for your balance. When you see things move, you watch things move, you feel moving, or when you close your eyes, you feel much worse because you rely more on your eyes for your balance. And when you can't use your eyes, it makes you feel dizzy. Or when you're at the grocery store and you see all the movement, you know, in your peripheral vision, or the depth and the colors and all that, that can make a person dizzy. So I'll just say, do you get dizzy watching things move? Is your problem worse in the dark? And then sometimes I'll do my smooth pursuit test. And if that makes them dizzy, I'll know they have visual dependence. Elaine Arone defined the highly sensitive person. She said about 15% of the population hears more, sees more, feels more. And I believe this to be true. She said they are the bloodhounds in the canine world of the human race. So I find this interesting. I find that my highly sensitive individuals experience dizziness different. So a highly sensitive person will experience AVS differently, or TEVS, or SEVS, or chronic vestibular syndrome. They will experience their dizzy worlds, and their dizzy moments will be much more vivid. And so I'll ask, do you startle easily? Do bright lights bother you? Do loud sounds bother you? Are you highly sensitive? Do smells bother you? The other thing I like to ask is, are you sensitive to caffeine? So I ask all these questions. And if they say yes, I'll know, okay, this is not just a person with BPPV and neck issues, but they also are highly sensitive. And now they have visual dependence, you know, and you can see how this dizzy pie, I call it. And some would say this is 3PD, that what I'm doing is I'm screening for 3PD as I'm going through this. Is the patient in fight or flight? Do they speak fast? Are they crying easily? Do they get more emotional? Do they seem like they could be more depressed? Are they asking a lot of what if questions, or what about, what about, what about? Do they startle easily when I do some of my tests, like the head impulse test, or when I add vibration? Because who's in fight or flight, they could be having anxiety, they could be hypervigilant, they'll feel more sway than what's actually taking place, they'll see more, everything's heightened. And so those are key questions I like to ask. And many of my patients are in this state. They have these issues. Now, few more key questions. I know there's a lot. Believe it or not, though, I get through these really fast now that I have my approach. But it's really important to ask your patients before you start working with them. Have you ever thrown up because of this? Are you nauseated right now as we speak? Have you ever become nauseated with this? Because if they say yes to any of those questions and they have BPPV, then they're probably going to get sick or could be more at a higher risk of getting sick with you. Now, the other thing that's important to ask is it okay if I make you dizzy today? Because they may have appointments later on in the afternoon, they may have a busy day ahead, and maybe they don't want to be dizzy in the morning, because if you make them dizzy in the morning, even if you fix them, you could still trigger their motion sickness. So, so those are key questions that I like to ask. And you can see there, do you have a history of motion sickness? If they say yes to those, I'm progressing very carefully. How about falls, fear of falls? Have you fallen? Are you afraid of falling? Do you think about falling? You know, there's some good fall questionnaires you can give patients, but that's how I screen for if a patient has fallen or they're afraid of falling. You can pretty much bet some of their dizzy sensation is coming from height vertigo, being on their own two feet. Okay. Dehydration. A lot of my older people do not like to drink water. They drink a lot of coffee, tea, a lot of caffeinated type foods that will dehydrate them and then give them orthostatic intolerance or lower blood pressure in general. And so they can feel weak all over. They can be more likely toward having low blood pressure. And so I ask some of these questions of diarrhea, vomiting, urine color, how many glasses of water do you drink a day? And then finally, perceiving normal sway as abnormal. These people are just going to say, oh, I'm just so off balance everywhere I go. But when they walk back, you're going to look at them and you're going to think they don't look that off balance, but it's because they're feeling normal movement is abnormal. So those are more objective question or test things that you look for. Finally, you want to ask, is there any history of antivert, meclizine, dramamine, scopolamine on Phenergan or Valium? Zofran or ondansetron is not a suppressant, but it's still good to know if they're taking it. But some of the central nervous system suppressants and the medications in general, you want to know if they're on any anti-seizure, any psychotics, antipsychotic drugs, different heart drugs, different medications are important to ask about because a lot of the side effects are dizziness. Sleep hygiene is important. Are they getting good sleep? Because if not, that could explain why they're not habituating, why they're not compensating. Their adaptive reserve might be limited by lack of sleep. And then finally, one of the most important questions is any changes in hearing with these spells? Does your hearing fluctuate? So those are very, very good questions. If you've done all of this, everything that I'm talking about, if you've asked all the trigger and timing based questions, your patient has filled out the DHI, they've completed the intake that I recommended there at the beginning. If you have followed this approach and then you ask the common problem screen, you're going to be setting yourself up and the patient for being able to be figure out the 75% of patients who can be diagnosed by history alone. It's a very thorough approach, very helpful. So I highly recommend it, and feel free to email me, call me, text me if you have questions about it. I'd love to hear your stories of victory. Oh, I want to show you, this is a sample, and all these links will be available to you guys. This is an example of a student that I recently had, and she did a great job of filling out these algorithms, and you can just see how it worked for her. I have several pages of this, and this is how we figured out what was wrong with all of these different cases. And I have, kind of written out, the details in these cases and kind of some of the objective findings that we've had with them. And so it's very helpful for you to see that. All right. Hey, thank you all for listening. Stay tuned. This is just a small part of our 12-hour course. I hope you join us again. Thank you.